retinal features that are present. So I think that this is the way to go back and test patients. The thing is, I'm hoping that I can advise Nidek and help them in terms of what I think is necessary for this. The problem is that if you imagine a person, let's say with geographic atrophy, who has a large scotoma, and you do some sort of regular conventional field, and the person misses, let's say you're doing 50 points, the person misses 35 of them. Now the next year they come back and the scotoma's enlarged, and so you're going to end up testing the same 50 points, and now the patient won't see 40 of them. Well, it's a very frustrating experience to sit there and not see most of the points, and also it becomes, you end up having few points in the area of interest. So I think the way to go really is to define a system of how you're going to construct the grids that you will test in subsequent years. But it's very, very doable with this. Okay, so this is a typical semi-automated test pattern, although I guess I was a little crooked on it. But so you sort of specify a grid, you define the density of the points, and then you test. Now this person, I knew by the history that he gave that he had a ring scotoma near the center. I felt certain that he did. But the problem is, when we did the testing initially, none of the points went in here. And it turns out here is where he had a very tight, like a bullseye scotoma, right around the fovea, but that spared sort of the area around. But then so I had added those points to really identify it, and then I could come back in, removing the cross, so that the cross is now not there, and isn't potentially blocking off or interfering with the perception of the stimuli, and then I could map it more effectively. So the semi-automated plot gives me a feeling of where there are problems, and then I can go back in and refine. And this is a patient with Stargardt disease. You can see the flex here. There's an area here of dense scotoma, and the patient really has quite stable fixation up here. On a fundus photograph, we all know that normally things are reversed. Right is left and left is right in terms of how it goes into the brain and what how it maps to the surroundings, to your visual field. But since when we take a fundus photograph, we're basically facing the person, we've already turned them around, so to speak, right to left. So right and left on a fundus photograph is the same as it is in visual field space, as the patient's sitting. But up and down is the reverse. So this person on the retina is placing the cross above the scotoma. That means in visual field space, the scotoma is up here, and they're looking up in order to move the scotoma out of the way to see. And this is another patient with geographic atrophy who sort of has like a horseshoe of atrophy, and oftentimes people who have that can sort of still use this little seeing retina area in here. This patient happened not to be able to, and had sort of unstable fixation peripherally. I was mentioning earlier, it's very interesting. I think that the MP1 in a sense has a bigger role in terms of macular degeneration since in wet macular degeneration, now that Lucentis and Avastin anti-VEGF agents are used. Because what happens is you can't really look at an eye anymore and say, I know exactly where that person is seeing and where they aren't, because you can have areas of scar and you think the person is not seeing there and they are seeing there. They can get better acuity than you think, and you can really sort of go in and sort of map out exactly where the person is fixating, and it's very, very, very useful. Another feature is the fixation module, and basically you're not doing perimetry there. You set the person up and just have them look at the cross for however long you want. Usually I do 15 or 20 seconds. And what you can get you can get this for perimetry as well. You get a little fixation map of what percentage of all the fixation points are within 2 degrees, a 2-degree circle centered on the fixation, and a 4-degree circle. So this it ranks it sort of as stable, relatively unstable, or unstable. Now this happened to be, he's a young man, he's about 18 or 19 now, with very mild albinism. He has some very subtle iris transillumination defects, and he doesn't seem to have any xanthophyll, which is characteristic of albinism. And you could sort of see that his fixation sort of maps out sort of along this line. And what you can generate also on the MP1 is I forgot what they call it on there, but it's a time map, let's say, of what happened to fixation. You can really see he had this real micro nystagmus that you almost couldn't see otherwise, but it's very easy to map out on here.